Assalamu alaikum. This is lecture number 7. It's about the ventilation perfusion relationship. Objectives of the lectures are: describe the primary function of the lung, that's to say gas exchange, review the mechanisms of hypoxemia, hypoventilation, diffusion limitation and shunt, discuss the concept of ventilation perfusion inequality, examine how ventilation perfusion inequality impairs overall gas exchange, and the last objective is that characterize the pathophysiology of abnormal ventilation perfusion inequality. Definition of the ventilation perfusion ratio. The ventilation perfusion ratio is the ratio of the whole ventilation to the pulmonary blood flow. The ratio for the whole lung at rest is about 0.8 to 0.9. This ratio is simply obtained by dividing the alveolar ventilation by the cardiac output. And since the alveolar ventilation is 4.5 to 5 liters per minute divided by 5 to 5.5 liters per minute, the ratio comes out with 0.8 to 0.9. However, in upright position, the ratio is less than 1. It's about 0.6 at the base of the lung, and greater than 1, about 2.5 at the apex. The most efficient gas exchange occurs when the ratio is approximately equals to 1. This slide explains why the ratio is the highest at the apex and lowest at the base of the lung. You can see here that at the bottom of the lung, the blood flow is greater than the ventilation, so the ratio will be less than 1. And at the apex of the lung, the blood flow is much less than the ventilation, and hence the ratio will be more than 1, while it is the best and equal to 1 at the level of rib number 3. Now, what is the effect of the ventilation perfusion ratio on alveolar gas concentration? There are 3 possibilities. First, the ratio is reduced to 0. Second, the ratio increases to infinity. And third, the ratio is within normal values. If the ratio equals to 0, and this occurs when no air reaches the alveoli, this situation leads to the shunt formation, as you can see in the right side of the diagram. The air in the alveolus equilibrates with blood oxygen and carbon dioxide. Since the perfusing blood is the venous blood returning to the lung from the systemic circulation, the alveolar partial pressure of oxygen sets at 40 millimeter mercury, and the partial pressure of carbon dioxide will be set at 45 millimeter mercury. Now, if the ratio increases to infinity, this occurs when no blood reaches the alveoli, as in pulmonary embolism. This situation leads to alveolar dead space formation, as you can see in the left side of the diagram. The alveolar air becomes equal to humidified inspired air, thus to say, the partial pressure of oxygen of 149 or 150 millimeter mercury, and a partial pressure of carbon dioxide of 0 millimeter mercury. And the last situation is when the ratio is normal and in normality, the alveolar partial pressure of oxygen, as I told you before, it's about 104 millimeter mercury, and usually we consider it 100. And the partial pressure of carbon dioxide is 40 millimeter mercury. Note, the term ventilation perfusion mismatch or inequality is more appropriate to be used to describe conditions fall in between these two extremes. Here are two important notes. The first note is that there can be marked decrease in oxygen tension with only a minimal rise in carbon dioxide tension. Please look at the graph. Simply, if there is an increase in carbon dioxide within the alveoli, this will shift greatly the concentration of the oxygen to a lower level, and vice versa. Many of the conditions, this is number two, note number two, many of the conditions that cause mismatch of ventilation and perfusion involve both dead air space and shunt. For example, in chronic obstructive lung disease, as an emphysema, for example, there may be impaired ventilation in one area of the lung and impaired perfusion in another area. This slide explains the clinical significance of physiologic shunt formation and the physiologic dead space formation. When there is physiologic shunt, as in pulmonary obstruction, the blood will not be fully oxygenated. This will lead to a decrease in arterial partial pressure of oxygen and a decrease in arterial oxygen content. On the other hand, if the ventilation perfusion ratio is greater than normal, as in pulmonary embolism, there will be an increase in physiologic dead space. The increase in physiologic dead space will cause carbon dioxide retention and hypoxia. Compensated hyperventilation will take place. However, the correction of hypercapnia will be more than the correction of the hypoxia. Now, what is the effect of exercise on the ventilation perfusion ratio? The cardiac output increases approximately linearly with work level. The change in cardiac output in liters per minute is only about a quarter of the increase in ventilation. Ventilation increases linearly with oxygen uptake until the ventilatory or anaerobic threshold is reached, after which ventilation increases more rapidly. Despite the increase in ventilation, the difference between the inspired and expired oxygen concentrations does not change. In normal subjects, the amount of ventilation perfusion inequality between the top of the lung and the base of the lung decreases during moderate exercise because of the more uniform topographical distribution of blood flow. In exercise, the partial pressure of oxygen and the oxygen content of the arterial blood remains stable at about 100 millimeter mercury. This is because of, first, the increase in ventilation. This increase in ventilation maintains a steep partial pressure of oxygen gradient across the blood gas barrier. Second, there will be an increase in tidal volume. This increase improves ventilation perfusion ratio at the lung bases. Third, increased pulmonary flow. The increase in pulmonary flow recruits pulmonary capillaries and increases blood gas interface surface area. This figure shows you that the partial pressure of oxygen in venous blood decreases during exercise. This decrease will simply increase the gradient at the alveoli. This figure summarizes the respiratory responses to exercise. Please note that the arterial partial pressure of oxygen and the arterial partial pressure of carbon dioxide remains almost constant during exercise, and the ventilation perfusion ratio becomes more evenly distributed in the lung during exercise, as we explained in the previous slides. This is a test question for you, as we used to do in previous lectures. If you want to discuss this question with me, you can write your questions to me and send it to me by email. Now, what are the pathophysiological explanation for the change in ventilation perfusion ratio? Basically, the change is either due to reduced perfusion of the lungs or reduced ventilation of the lungs. Regarding reduced perfusion of the lungs, this finding is typically associated with pulmonary embolism. Ventilation is wasted as it fails to oxygenate any blood. The ventilation perfusion ratio is high, with decreased partial pressure of carbon dioxide in the alveoli and increased partial pressure of oxygen in the alveoli because of the increased dead space ventilation. The partial pressure of oxygen in the arterial blood is reduced, and thus also the peripheral oxygen saturation is lower than normal, leading to tachypnea and dyspnea. For the reduced ventilation of the lung, there will be reduced ventilation can occur for a number of reasons. This includes pneumonia, whereby the alveoli are filled with exudate, limiting the ability to maintain ventilation. Also, asthma and chronic obstructive pulmonary disease may also result in a reduction in ventilation, as well as respiratory distress syndrome of the newborn, whereby reduced surfactant production results in multiple collapsed alveoli, limiting its ventilating capacity. The effect of reduced ventilation is hypoxemia. However, as the rest of the lung can still remove carbon dioxide, hypercapnia does not occur. In severe asthmatics, aerosolized bronchodilator therapy by increasing blood flow to potentially underventilated lung units increases shunt and arterial desaturation. This may lead to worsening hypoxemia following bronchodilator therapy. Drugs such as anesthetics can lower ventilation perfusion ratios, as there is impaired matching of ventilation and perfusion during anesthesia. The pathophysiology in some pulmonary diseases is complex and can be associated with multiple pathologies. Prolonged smoking can end in chronic obstructive lung disease such as emphysema. Please note that emphysema can have dual effect. It can cause bronchial obstruction. This will end in decreased ventilation and makes the perfusion ventilation ratio approximate zero, thus to say shunt formation. On the other hand, emphysema causes enlarged alveolar sacs. This will cause wasting of ventilated air. This will increase the physiologic dead space. The effectiveness of gas exchange can be reduced in emphysema to 1/10 the normal value. This question regards the ventilation perfusion ratio. Again, if you have difficulty in solving this question, or if you have any question about it, please contact me by the email. I hope this lecture was informative for you. Thank you.